So the question is role of autologous transplantation in patients with newly diagnosed de novo high-risk diffuse large B-cell lymphoma. We are not talking about genomically defined high-risk diffuse large B-cell lymphoma such as double expressors or double hit diffuse large B-cell lymphomas. So for the purposes of this discussion, we are talking about diffuse large B-cell lymphoma patients who have high-risk disease based on the widely used international IPI score or other similar clinical scores. The role of transplantation in this setting in all the studies evaluating that question can be divided into two eras: studies conducted before rituximab's incorporation into practice and studies conducted after rituximab's incorporation into practice. In the pre-rituximab era, there were at least 7 or 8 randomized trials which asked that question, and a meta-analysis of all these trials together did not show a clear benefit of early transplantation in clinically defined high-risk diffuse large B-cell lymphoma patients. However, after the rituximab approval, the key SWOG study randomized high-risk diffuse large B-cell lymphoma patients to either consolidation with an autologous transplant or no autologous stem cell transplantation. In all comers, the study did not show a survival benefit with the use of autologous stem cell transplantation. However, an unplanned analysis of high-risk IPI patients suggested a survival benefit with autologous stem cell transplantation. There are certain caveats to that study. The SWOG analysis only included diffuse large B-cell lymphoma patients in addition to other types of aggressive lymphomas. In fact, diffuse large B-cell lymphoma constituted only about 60% of the patients on that study. Another weakness of the study is that the SWOG study included patients who got both Rituxan-based frontline therapies and patients who did not get rituximab-based therapies. So the question of autologous stem cell transplantation in patients who uniformly receive R-CHOP-like therapies in the frontline setting remains controversial. However, I should highlight two studies. A study led by Norbert Schmid from the German group uniformly treated patients with Rituxan and anthracycline-based therapies and then randomized those patients to chemotherapy alone versus successive rounds of high-dose therapy and autologous stem cell transplantation, and did not show a benefit with autologous stem cell transplantation in that setting. Recently, a second European study published in Journal of Clinical Oncology in October of 2016 also assessed the role of transplantation in Rituxan-treated aggressive diffuse large B-cell lymphoma patients, and again in that study, no benefit of early application of high-dose therapy and autologous transplant was seen. So my bias is that in clinically defined high-risk diffuse large B-cell lymphoma patients, routine use of early high-dose therapy and autologous stem cell transplantation is not perhaps warranted.